Hello students, welcome to Concepts of Care for patients with arthritis and total joint arthroplasty. So this is part 4. We're going to speak about rheumatoid arthritis and gout. So before any theory, let's watch this video so we can have general information about rheumatoid arthritis. This is an extremely important point for you to know.
Bones provide support for the body and aid in its movement. The place where two or more bones meet is called a joint. Joints may be immovable, slightly movable, or freely movable. A synovial membrane surrounds movable joints. Inside the membrane, synovial fluid lubricates and nourishes joint tissue, such as cartilage. Articular cartilage is a tough, slippery covering on the ends of the bones, which allows smooth joint movement. Joints give the body flexibility, precision of movement, and help in supporting the body's weight. Arthritis is any disorder that affects joints. It can cause pain and inflammation. Rheumatoid arthritis is the second most common type of arthritis. The joints most commonly affected are in the wrists, hands, knees, ankles, and feet. It typically occurs at the same joint on both sides of the body. It can also affect other organs in the body, such as the eyes, skin, heart, lungs, kidneys, nervous system, and digestive tract.
That's everything.
Rheumatoid arthritis is an autoimmune disorder. This means the body attacks itself by mistake. In rheumatoid arthritis, the immune system attacks joint and organ tissues. Here's how it happens. The white blood cells of the immune system move into the joint. They release chemicals called cytokines, which attack the cells of the synovial membrane. These chemicals cause synovial cells to release other destructive substances. They also cause the synovial membrane to grow new blood vessels and form a thickened area called a pannus. Over time, as the pannus grows, it invades and destroys areas of cartilage and bone inside the joint. Inflammation causes fluid buildup in the joint, making the joint swell. Eventually, without treatment, the joint space narrows and ankylosis can occur. Ankylosis is fusion or growing together of bones in the joint. This results in the loss of the ability to move the joint. There is no cure for rheumatoid arthritis. However, doctors commonly prescribe various combinations of the following medications that, when taken together, can reduce inflammation and pain and slow down joint damage. These include non-steroidal anti-inflammatory drugs, or NSAIDs, steroids, and standard disease-modifying anti-rheumatic drugs, or DMARDs. If standard DMARDs aren't working, doctors may prescribe newer drugs called biologics, also known as biologic DMARDs. Physical and occupational therapy, along with low-impact exercise, can increase muscle strength and help keep joints limber. For severe rheumatoid arthritis that has not been helped by other treatments, a doctor may recommend a surgical procedure. For example, a joint replacement procedure, also known as an arthroplasty, may be recommended. For joints that are difficult to replace, joint fusion, also known as arthrodesis, may be recommended. During this procedure, the joint is removed and the bones are fused together with bone graft. Another surgical procedure for severe rheumatoid arthritis is a synovectomy. During this procedure, the synovial membrane surrounding the joint is removed. In some cases, an arthritic joint may need to be replaced with an artificial joint. For more information, talk to a healthcare provider.
Thank you so much. This was a very complete video about the disease, right? So now it's our turn to review. Okay, so this is a chronic progressive systemic inflammatory autoimmune disease. Systemic when we consider all the organs that are involved, from the eyes, the heart, connective tissue, the wrist, different joints, right? Especially the wrist, the ankles, and the knees. Is autoimmune disease process that affects primarily the synovial joints. Systemic means that this disease can affect any or all parts of the body while affecting many joints, correct? So transform autoantibodies, rheumatoid factors that attack healthy tissue, especially synovium, are formed causing inflammations. So basically, these antibodies are the ones that are causing the inflammations. The disease then begins to involve the articular cartilage, joint capsule, and surrounding ligaments and tendons. Immunity and inflammatory factor cause cartilage damage in patients with rheumatoid arthritis. So then, let's start by understanding what is the autoimmune action that is causing this. What are the soldiers that are causing this autoimmune reaction? So we have the CD4 helper T cell. Helper T cell, let's remember that these T cells are under the lymphocytes umbrella, right? So we have a helper T cell that help your other immune cells. These T cells are helping other immune cells. Some T cell helpers help the B cells make antibodies against foreign invaders. So when we remember the B cells, we are going to remember B of body. So we know the B is making antibodies, right, against foreign invaders. Others help activate cytotoxic T cells, okay? So there are different types of T cells. We have the cytotoxic T cell, we have the killer T cell, we have this helper T cell. In this particular disease, we are talking about the helper T cells, the CD4. Another immune cells in synovial fluid promote cytokine release. We know that is cytokine signaling, especially interleukin-1. So what is interleukin-1? Interleukin-1, because there are many interleukins, but in this situation is interleukin-1 that has a wide range of biological functions, which include acting as a leukocytic pyrogen, a mediator of fever, and leukocytic endogenous mediator. So interleukin is going to signal, is going to understand that there is something causing a little bit of fever, okay? So it's going to act, but this is wrong. All the signals are wrong, right? So T cells are sending signals to start promoting B cells antibodies. Then interleukin is signaling or is sensing that maybe there is some infection, some mild fever, and then tumor necrosis factor alpha, which is another soldier of the immune system, It's a protein in the body and is important for your immune system for protection and defense. It is also involved in healing. But if tumor necrotic factor works by causing inflammation and this inflammation is not regulated, this chronic state and participation of the tumor necrosis factor can cause a chronic inflammation. So then you have the T cells signaling that something is going on. Please, B cells, be ready, prepare antibodies. Then interleukin is feeling that there is some infection, fever, whatever. And then the tumor necrosis factor is coming into place to cause inflammation, right? Which attack cartilage. Neutrophils and other inflammatory cells in the joint are activated and break down the cartilage. We know that the neutrophils are the biggest, the larger army under the umbrella of the white blood cells, right? Nurse love to monitor. So immune complexes deposited in synovium and osteoclasts are activated. Due to this breakdown the cartilage or breakdown in general, osteoclasts are activated. We know already what is osteoclast. B and T lymphocytes on the immune system are stimulated and increase the inflammatory response. So all these soldiers are starting to fight against something that does not exist. It's an autoimmune response, okay? They are overreacting. Hyperemic, the synovium then thickens and forms hyperemic. So hyperemic is a consequence that causes a lot of vascularity, a lot of circulation, right? And so fluid accumulates in the joint space, and pannus, okay, so hyperemic increases the blood flow and pannus forms. The pannus is vascular granulation tissue composed of inflammatory cells. It erodes articular cartilage and eventually destroys the bone. Let's stop there. So what happened is, due to this high vascularity, the blood that is getting involved in this particular tissue is blood with a high content of soldiers from the immune system that are attacking. Okay, that is not like a healthy blood and plasma. It's coming too many soldiers that are attacking. So as a result, in late disease, fibrous adhesions, bony ankylosis, abnormal fusion of bones in the joint, as we saw in the video, and calcifications occur. Bone loses density and secondary osteoporosis exists. Perfect. Permanent joint changes may be avoided if rheumatoid arthritis is diagnosed early. Early and aggressive treatment to suppress synovitis may lead to a remission. Rheumatoid arthritis is a disease characterized by natural remissions and exacerbations flares up. Let me review. Permanent joint changes may be avoided if rheumatoid arthritis is diagnosed early. Early and aggressive treatment to suppress synovitis may lead to remission. So if this is identified early and proper treatment is started early, those soldiers are going to be attacked and they're going to be killed. Preventing flares help prevent joint erosion and permanent joint damage. Okay, because rheumatoid arthritis is a systemic disease, areas of the body besides the synovial joints can be affected. Inflammatory responses similar to those occurring in synovial tissue may occur in any organ of body system, meaning that the attack is not going to be only in the synovial joints, but also in any organ or connective tissue, including the eyes, right? In which connective tissue is prevalent. If blood vessel inflammation, vasculitis occurs, the organ supply by that vessel can be affected, leading to eventual failure of the organ or systemic in late disease. Okay. Etiology, combination of environmental and genetic factors. Female productive hormones influence the development of RA. We are going to call it that way from now on, rheumatoid arthritis, RA, because it affects women more often than men, usually young to middle-aged women. Others suspect that infectious organisms may play a role, particularly the Epstein-Barr virus, the one that causes mononucleosis. Okay, I think we spoke about this at some point in the nervous system chapter, right? Epstein virus. Physical and emotional stressors have been linked to exacerbation of the disorders and may be contributing factor or trigger to its development. Okay, so rheumatoid arthritis and immunity research has shown that there is a strong association between RA and several human leukocyte antigens. Which is your DR alleles. The cause of this association is not clear, but most HLA diseases are autoimmune. So many people, many of my medical assistants or nurses that I train sometimes, they're asking me, what is the difference, Dr. Matalana, between antigen and antibody? Okay, so the difference between an antigen and antibody is that antigen is a foreign substance that induces an immune response, while an antibody is a glycoprotein that is produced in response to this to counteract a particular antigen. So antigen is coming from outside, and antigen is produced in the body, and antibody is produced in the body in order to counteract, to protect the body from the antigen. Now, antigen can be lipids, carbohydrates, nucleic acids, or proteins, while the antibody is always a protein. So, explaining that in proper English, and critical thinking nurses are going to right now make a rationale. If I have an antigen that can be lipids, antigen can be cholesterol, excessive fat, right? So those can signal antibodies in our immune system. Now, carbohydrates, the diabetic patient eating too much sugar, that can signal our body that an antigen is coming. Let's remember that cancer loves to eat sugar and fats. Okay, now nucleic acids or proteins. What about your proteins that are very from bad quality? You are eating meat that is not organic, right? That is not grass-fed. So all these things are received by the body in the form of antigens, and the body is going to create an antibody as a defense mechanism to protect us from these substances. Okay, so that's the difference between antigen and antibody. Incidence and prevalence. RA affects over 1.5 million people, and whites have the disease more often than other groups. Women are 2 to 3 times more likely to have RA compared with men. So far we have described how the pathophysiology of the condition is. We also have described the participation of antigen and the antibody, and with that we can start developing a nursing care. Our critical thinking start telling us that we need to improve our nutrition or whatever enters in our body. Okay, so health disparities in rheumatoid arthritis. African Americans have a higher prevalence of rheumatoid arthritis, particularly those who have an educational level of less than high school and low family income. Right there, low family income. These patients that are not having a good nutrition are buying full food that are coming in cans or packages, okay, with a lot of chemicals. So if you have a genetic let's say that you have a genetic in a gene or something in your blood, but you on top of that are giving these bad nutrients that are having full of chemicals, so the environment of the cell is being totally toxic, right? Versus if you have the gene, but you are creating a nice environment with good nutrition, supplements, organic food, now that gene maybe is not going to develop fully to the point to generate rheumatoid arthritis. Follow me on this, my dear nurses students, okay? Recognize cues assessment. The onset of rheumatoid arthritis may be acute and severe or slow and progressive. Patients may have vague symptoms that last for several months before diagnosis. The onset of the disease is more common in the winter months than in the warmer months. The signs and symptoms of RA can be categorized as early or late disease and as joint articular or systemic extra-articular. Joint disease, late disease, early or late disease, and joint articular or systemic when it's extra-articular, meaning that not only the joints but other organs or connective tissue. So now we have the early signs and symptoms of rheumatoid arthritis. We have in the early signs inflammation, versus in the late signs inflammation is already the first step. Now we have deformities. In the late signs, we have deformities, we have the swan neck or ulnar deviation, and we have moderate to severe pain and morning stiffness. Okay, this is severe late signs of the severe disease. Let's identify what is a swan neck. Easy and simple, so you can start visualizing what these patients are going through. Swan neck is very common, typical in rheumatoid arthritis. My computer is taking forever. Classic snapping swan neck deformity. You see, those are the rheumatoid arthritis swan neck. Okay, thank you so much. And I think the chapter also has some images. So in the early, we have just inflammation. We're going to have in the systemic part, maybe low-grade fever, right? Because all these soldiers, especially the interleukin, is going to identify there is some infection, there is low-grade fever, there is a fighter, fatigue, weakness, anorexia, paresthesias, right? Dr. Matalana, what is paresthesias? Paresthesias is a sensation of prickling and or tingling on arm, leg, or foot skin, okay? And all this description in this table is good to know. That's good to know. Now, versus the systemic in the late disease or severe stage of RA, you are having not only signs and symptoms, you are having already a disease going on. You have osteoporosis, severe fatigue, because these patients with that pain and these deformities, I bet you they cannot sleep and have good comfort, good rest, right? They're going to have anemia maybe, right? Weight loss, muscle atrophy, subcutaneous nodules, peripheral neuropathy, vasculitis, pericarditis, fibrotic gland disease, Sjögren's syndrome, which is a syndrome. This is an autoimmune disorder. The symptoms of this disorder are dry eyes, dry mouth, and it affects the mucous membrane and moisture secreting glands. Let me tell you something. Any patient that is having an autoimmune disease, okay, is in high risk to develop multiple autoimmune diseases. Okay, so RA, Sjögren's syndrome, probably other autoimmune condition, okay, that right now I cannot remember, but multiple autoimmune conditions, okay, like sickle cell, okay. So with this type of patients, you need to consider that the approach has to be a collaborative, multidiscipline approach, right? Physical assessment, signs and symptoms. In the early stage RA, the patient typically reports joint inflammation. And maybe you're going to ask me, Dr. Matalana, why a patient having an autoimmune condition can develop multiple autoimmune conditions? And the reason is simple. Since you're having some malfunction in your immune system, the immune system is going to express itself in any part of the body, right? The weakest part of the body with the biggest problem, the immune system is going to express. Okay, so it's the whole immune system that is expressing in different areas. So let's go back to RA. The patient typically reports joint inflammation, generalized weakness, and fatigue. Anorexia, weight loss of about 2 to 3 pounds, and persistent low-grade fever are common. So in early stage, we have generalized weakness, fatigue, anorexia, weight loss, persistent low-grade fever. In patients with early disease, the upper extremity joints are involved initially, right? Meaning the wrists. Often the proximal interphalangeal and metacarpophalangeal joints of the hands. These joints may be slightly reddened, warm, stiff, swollen, and tender or painful, particularly on palpation caused by synovitis. So it's going to be reddened, warm, stiff, swollen. Okay, the typical pattern of your involvement in RA is bilateral and symmetric. The number of joints involved usually increases as the disease progresses. And I forgot to put, this is good to know. This is the answer to one of the mastery at the end of this chapter. That's good to know, okay? Every single symptom here is going to be the answer of the mastery question at the end of the chapter. The presence of only one hot, swollen, painful joint out of proportion to the other joints may mean that the joint is infected, because in RA, remember, is bilateral. Refer the patient to the primary healthcare provider, generally the rheumatologist, immediately if this is the case, because maybe they are going to start antibiotics immediately if it's only one joint, right? The patient usually has frequent morning stiffness, we know that, which can last for several hours after awakening. The patient usually has frequent morning stiffness, I read that also. Note any muscle atrophy, which can result from disuse secondary to joint pain, and a decreased range of motion in the affected joint. So you need to monitor that and try some nursing care, some teaching in how to move the joints in order to avoid this muscle atrophy. The temporomandibular joint, which is the one next to the ear, right, next to the earlobe, and it's the beginning of the mandible, right? The mandible. So whenever you are eating, you can feel the bone next to your mandibular and low to below the ear. Okay, that's the temporomandibular. May be involved in severe disease, but such an involvement is uncommon. When the TMG is affected, the patient may have pain when chewing or opening the mouth. When the spinal column is involved, the cervical joints are most likely to be affected during clinical examination. Gentle palpate the posterior cervical spine and identified it as a cervical pain, tenderness, or loss of motion. We spoke about this in a previous chapter. I think it was during hip replacement when the patient is going to receive anesthesia right before the procedure, and they do a number of assessments, and they planify how the procedure is going to be, and they want to know what is going to be the prognosis procedure. And in case they need to intubate the patient, they want to make sure that the patient doesn't have this cervical spine compromise, because it can cause subluxation, right? So especially if the patient is having a diagnosis with rheumatoid arthritis. So we spoke about this too. Cervical rheumatoid arthritis may result in subluxation, especially of the first and second vertebrae. This complication may be the life-threatening condition because branches of the phrenic nerve that supply the diaphragm are restricted and respiratory function may be compromised. This is a very high area in the cervical. The patient is also in danger for becoming quadriplegic, weak in all extremities. Remember, the higher the damage in the spinal cord, the higher the high probabilities to be quadriplegic, right? If cervical pain may radiate down one arm or loss of range of motion is present in the cervical spine, keep the neck straight in a neutral position to prevent permanent damage to the spinal cord or spinal nerves. And that's good to know. NCLEX alert. Joint deformity occurs as a late articular manifestation, and secondary osteoporosis can cause bone fractures. Observe common deformities, especially in the hands and feet. Okay, this happens in these rheumatoid arthritis patients. Extensive wrist involvement can result in carpal tunnel syndrome. I taught you how to identify if somebody has carpal tunnel syndrome. Gently palpate the tissues around the joints to elicit pain or tenderness associated with other rheumatoid complications, unless the patient is having severe joint pain. For example, Baker's cyst, enlarged popliteal bursae behind the knee. And I'm going to play a video right now so you can be familiarized with Baker's cyst. Since we are studying rheumatoid arthritis, we need to be familiarized with all the different symptoms and manifestations in the body. Okay? Okay.
Doctor, what's this? Well, this is something called a Baker's cyst, and it's a fluid-filled swelling that develops at the back of the knee. Here are 3 things that you need to know. This happens because the tissues behind the knee joint become swollen and inflamed, and this might cause pain in the knee and the calf, a buildup of fluid around the knee, or occasional locking or clicking in the knee joint. Sometimes they can burst, which can cause a sharp pain and swelling in your calf. Most of the time, these can be diagnosed by your doctor asking you some questions and examining it. Sometimes, to rule out other conditions like a blood clot, the doctor might order a scan. If it's not causing any symptoms, treatment usually isn't needed. For swelling and pain, it's recommended to try painkillers first, a knee support or an ice pack. But if all of these don't help, then you should see your doctor.
Thank you so much.
Doctor, what's this?
So that was Baker's cyst. Okay. So numerous extra-articular signs and symptoms are associated with advanced disease. So Baker's cyst could be one of them. Some patients have the characteristics of round, movable subcutaneous nodules, which usually appear on the ulnar surface of the arm, on the fingers, or along the Achilles tendon. These nodules can disappear and reappear at any time and are associated with severe destructive disease. So we are going to see subcutaneous nodules in the late stage, okay? Not in the early stage, because these nodules are associated with severe destructive disease. And I want you to pay attention to that, okay? Remember, rheumatoid nodules are usually not a problem themselves. However, they occasionally open and become infected and may interfere with ADLs. Inflammation of the blood vessels results in vasculitis, we know that, particularly of small to medium-sized vessels. When arterial involvement occurs, major organs can become ischemic and malfunction. So this is the horrible, the life-threatening part of the rheumatoid arthritis, when not only is causing the joint problem, but also is extending to the organs and connective tissue. Assess for ischemic skin lesions that appear in groups as small brownish spot, most commonly around the nail bed. So we are looking for a small brownish spots, most commonly around the nail bed. Assess any large lesion that appear on the lower extremity. These lesions can lead to ulcerations, which heal slowly as a result of decreased circulation. Peripheral neuropathy associated with decreased circulation can cause foot drop and paresthesias. We already reviewed what is paresthesias, burning and tingling sensations, usually in older adults. So here we have the swan neck deformity, which is image B. And also we have the boutonniere deformity. So doesn't have the swan neck form, but it's also like a very bended finger, right? Respiratory complications may manifest as pleurisy, pneumonitis, diffuse interstitial fibrosis, and pulmonary hypertension. Cardiac complications include pericarditis and myocarditis. And assess for eye involvement, which typically manifests as iritis and scleritis. So that's good to know, eye involvement, okay? Several syndromes are seen in patients with RA. The most common is Sjögren's syndrome. We spoke dry eyes, dry mouth, and dry vagina in some cases. Psychosocial assessment, physical limitations, and persistent pain may limit the patient mobility. And this can cause extreme fatigue, often causes patient to desire an early bedtime and napping, and may result in a reluctance to socialize. And when the patients, how can I explain to this? When the patients are having the need to have frequent naps, this would be like a step one into depression, in depression pathway. Okay, what is the common behavior of a patient who has a depression? They go to bed, they want to sleep, they want to forget about reality, right? So yes, we need to allow rheumatoid arthritis to go to bed because they are with fatigue, but we need to involve them in different activities in order to keep going. We want to prevent depression, right? Body changes caused by joint changes and drug therapy also is going to cause poor self-esteem. The patient may grieve or experience degrees of depression. Yes, as I was mentioning before, this is not an easy disease. Laboratory assessment, the test for rheumatoid factor measures the presence of unusual antibodies of the immunoglobulins IgG and IgM, types that develop in a number of connective tissue diseases. So that's a good piece of information for you, your IgG and IgM that develops in a number of connective tissue diseases. And we were talking about the rheumatoid arthritis not only attacks the joints, but the heart, different organs, the heart, the lungs, the kidneys, the eyes, and also the connective tissue. Many patients with RA have a positive titer greater than 1 in 8, especially in older adults. However, the presence of the rheumatoid factor is not diagnostic for RA. Okay, it's important, but it's not the definitive test for diagnosis for RA. One of the newest laboratory tests used to detect the level of anticyclic citrullinated peptide, anti-CCP, is very specific and sensitive in detecting early RA. That's good to know. The antinuclear antibody ANA test measures the titer of a group of antibodies that destroy the nuclei of cells and cause tissue death in patients with autoimmune disease. So if you want to know if there are antibodies that are having a bad behavior and are destroying the nuclei of cells, right, and causing these cells death, in the autoimmune disease, that's your ANA. An elevated erythrocyte sedimentation rate, ESR, or set rate greater than 20 can confirm inflammation or infection anywhere in the body. Anywhere in the body. The test is most useful to monitor the course of a disease, especially for inflammatory autoimmune diseases. In general, the more severe the disease gets, the higher the ESR, your sedimentation rate, rises. As the disease improves or goes into remission, the ESR level decreases. But here comes my favorite. Measurement of the high sensitivity C-reactive protein, or your hsCRP, is another useful test to measure inflammation and may be done with or instead of ESR. This is more sensitive, the CRP. It is also very useful for detecting infection anywhere in the body. The presence of most chronic diseases usually causes mild to moderate anemia, right? Which contribute to the patient's fatigue. Therefore, monitor the patient complete blood count. We know that we have spoken about anemia, so we need to measure the CBC for low hemoglobin, hematocrit, or red blood cells. We need to also take a look to the white blood cell count, if it's consistent with an inflammatory response. A decrease in WBCs may indicate Felty syndrome, a pulmonary complication associated with late rheumatoid arthritis. Let me extend on this. So also called Felty syndrome is a rare autoimmune disease characterized by a triad of rheumatoid arthritis, enlargement of the spleen, and low neutrophil count. So when we say, if I repeat what the book is saying, a decrease in the WBC count, having into consideration that WBC has many soldiers, right? Your nurses love to monitor. But this statement here is very generalized because really what is low is the neutrophil. Okay, so probably the WBCs are going to be low, but if you consider neutrophil lymphocytes and monocytes, you're going to see the big difference in the neutrophil count. So you're going to see the neutrophil, the enlargements of the spleen that is going to be assessed by the provider, not by the nurse, because you don't want to cause a rupture in the spleen. And also you're going to see the diagnosis of rheumatoid arthritis by any of the previous markers that we described before, right? So that's the triad of Felty syndrome. And then you're going to see thrombocytosis. Increased platelets can also occur in patients with late RA. Additional laboratory tests may be performed depending on the body systems and organs that may be affected by the disease. For example, if heart involvement is suspected, the primary healthcare provider may request cardiac enzyme testing. Okay, let's continue. So we have other diagnostics are going to be the standard X-ray to visualize the joint changes and deformities typical of RA. A CT scan may help determine the presence of and degree of cervical spine involvement, which is usually common, cervical spine involvement in patients with rheumatoid arthritis. And arthrocentesis, right, is the test. It's an invasive diagnosis procedure that may be used for patients with joint swelling caused by excess synovial fluid effusion. And we are going to watch the video, of course, because we want to know in detail what is the arthrocentesis, right? Especially you, my dear students. Okay, let's watch this video together.
As part of your medical treatment today, your doctor has recommended that you undergo a procedure called an arthrocentesis. There are many reasons to perform this procedure, including significant joint swelling, concern for joint fluid infection, or to relieve pain. You may ask your doctor for the specific reason you require an arthrocentesis if you are uncertain. The goal of this procedure is to remove fluid from your joint. A joint is the area where two bones meet, such as your knee, shoulder, wrist, hip, or ankle. In order to collect fluid, a needle will be inserted carefully into your joint. In general, only a small amount of fluid will be removed to collect joint fluid for testing. This is a relatively common procedure, performed approximately 75,000 times per year in the U.S. The results of this test will help the doctor decide how to best treat you further. This procedure will occur in your room and usually takes approximately 30 minutes, including setup. The laboratory testing of the fluid that is collected usually takes approximately 2 hours. In preparation for the procedure, your doctor will tell you how to position yourself and your joint in order to improve the chance of success for the procedure and minimize pain. It is very important that you do not move abruptly, as sudden movement can dislodge or move the needle. Sometimes, the doctor will also use an ultrasound machine to help choose the safest location to insert the needle. After choosing a location, the doctor will wash your skin with a powerful soap. Your doctor may then choose to administer pain medication under the skin in the same location that the needle will enter. Next, a needle will gently be inserted in your joint until fluid can be drawn back. You will feel a prick when the needle is inserted. Some patients may also receive pain medication by mouth before the procedure. As fluid is removed from the joint, some patients feel relief of pressure and pain. The fluid flows slowly through the needle. If your doctor removes a small amount of fluid for testing, this can take up to 1 minute. The needle may look long, but will be inserted the shortest distance until it can draw back fluid. The most common risks of this procedure are similar to the risks of a needle insertion anywhere else in your body and include pain, bleeding, infection, or hitting nearby structures. Your doctor will review your laboratory results and perform the procedure with sterile equipment to minimize these risks. These risks rarely cause permanent damage. There is also a possibility that the doctor is unable to obtain joint fluid. Small amounts of fluid, obesity, or difficulty holding the correct position are common causes. Very rare, but life-threatening risks of this procedure are serious bleeding or infection. Our doctors strive to always act in the best interest of you, their patient, and would not recommend this procedure if they believe that the risks outweighed the benefits of this procedure. Thank you for listening to this video, and please feel free to replay the video as needed. Your doctor and nurse will be happy to answer any.
Thank you so much. What a great video by this institution, Stanford University. So we now know what is the arthrocentesis, right? So the fluid is analyzed for inflammatory cells and immune complexes, including rheumatoid factor. Fluid from patients with RA typically reveals increased WBCs, cloudiness, and volume, right? Teach the patient to use ice and to rest the affected joint for 24 hours after arthrocentesis. That's our part, nursing care. Often the primary care provider will recommend acetaminophen as needed for discomfort. We always want to check how are the liver enzymes before that. If increased pain or swelling occurs, teach the patient or family to notify the primary healthcare provider immediately. MRI may be performed to assess spinal column disease or other joint involvement because RA can affect multiple body systems. Tests to diagnose a specific systemic manifestation are performed as needed. For example, nerve conduction studies help confirm peripheral neuropathy. Pulmonary function tests help determine the presence of lung involvement, and that's excellent to be performed by the doctor, so they are fully aware of what is the real state and stage of the RA patient. So we have a question here. We are going to read the question of the question first. Which of the following assessment findings would the nurse suspect that are related to the client's arthritis? So what are the common findings that the nurse is suspecting on this particular patient? Who is this patient? The nurse is caring for a client who has severe, advanced rheumatoid arthritis, who is admitted to the urgent care center. They are asking you what are the symptoms, what is the presentation of a severe, advanced rheumatoid arthritis. So low-grade fever, no, that's on an early stage. Hand joint deformities, yes. Report of severe fatigue, yes. Inflamed wrists and ankle joints, yes. Morning stiffness, yes. Everything is related to severe state. Okay, so we need to the priority collaborative problems for patients with rheumatoid arthritis include chronic inflammation and persistent pain, potential for decreased mobility due to joint deformity, and potential for decreased self-esteem image due to joint deformity. So the expected outcome for management is that the disease goes into remission and its progression slows to decrease pain, prevent joint destruction, and increase mobility. And managing chronic inflammation and pain, the patient with RA is expected to have a pain level 2 to 3, right? In a scale of 0 to 10, a major focus of pain management is drug therapy to modify or prevent the progression of the disease, thereby decreasing joint and systemic inflammation. Because remember, we need to control the progression in order for the patient to have less pain, okay? So we have to move fast, either with medication, right, to prevent the progression of the disease. Interventions. What are we going to do? This is a team that is going to manage pain by using a combination of pharmacology and non-pharmacologic measures. Total joint arthroplasty may be indicated when other measures fails to relieve pain. This is in case of severe RA. So drug therapy, we're going to use NSAIDs, and sometimes used for early RA to help decrease pain and inflammation. Other drugs affect immunity through immunosuppression. That's modifying the progress of the disease to reduce pain and inflammation. So remember, we need to control those crazy soldiers, you know, the CD4, the T cells, the interleukin, the tumor necrosis factor. We need to control them, Rene. They need to behave. Initially, most patients are managed with disease-modifying anti-rheumatic drugs, the DMARDs. And let's see what is the first line disease-modifying anti-rheumatic drug. So methotrexate, which is an immunosuppressive medication, is a type of chemotherapy, is a low once-a-week dose, once a week, is the mainstay of therapy for RA because it is effective and relative inexpensive. So your methotrexate, okay, is a slow-acting drug taking 4 to 6 weeks to begin to control joint inflammation. 4 to 6 weeks, meaning 4 to 6 doses, because remember, this is a once-a-week dose, okay? After 6 doses, between 4 and 6, you're going to start seeing the effects. Monitor patients for potential adverse effects, such as decrease in WBCs. This is a chemotherapy, is going to kill is going to put in order all these crazy soldiers, but also is going to decrease the WBCs or platelets as a result of bone marrow suppression or elevation in liver enzymes or serum creatinine. So keep an eye on the liver enzymes and your WBCs and platelets, okay? Patients taking MTX, methotrexate, are at risk for infection, of course, caused by impaired or decreased drug-induced immunity. Of course, if we have a decrease in WBCs, we are at high risk for infection. Teach them to avoid crowds and people who are ill. Any patient that is having an autoimmune condition receiving an immunosuppressant drug needs to avoid crowds. Remind patients to avoid alcoholic beverage while taking MTX to prevent liver toxicity, right? We discussed this. If we are taking any medication, we need to wait at least 8 hours to get alcohol. In this case, okay, we need to avoid alcohol because methotrexate is an immune suppressive drug, okay? We need to prevent liver toxicity. Probably we are going to see side effects like mouth sores, acute dyspnea from pneumonitis, okay? So we can support these effects and the kind of side effect in the bone marrow by supplementing with folic acid and other B vitamins to help decrease some of the drug side effects, but most important, the folic acid and the B12 or the B vitamins are to reinforce the production of good blood cells, okay? And that's good to know. This is NCLEX alert. Pregnancy is not recommended while taking methotrexate because birth defects are possible. Strict birth control is recommended for childbearing women who are in need of MTX to control their RA. Another DMARD sometimes used for RA is hydroxychloroquine, very popular in these years. In Africa, in other countries, they were using this medication, which is an antiparasite for COVID, right? This drug slows the progression of mild rheumatoid disease. This is an malarial drug that prevents suppressed immune response to decrease joint and muscle pain. Is not approved for COVID treatment here in the United States, the hydroxychloroquine. The drug should not be used for patients who have non-cardiac disease or dysrhythmia. So that's good to know also. Okay, safety alert. Hydroxychloroquine cannot be used in patients who have non-cardiac disease or dysrhythmias. And then the most serious adverse effect of hydroxychloroquine is retinal damage. So there you go. You have two things you need to remember with hydroxychloroquine: cardiac disease, patients with cardiac disease history or dysrhythmias, and also those who are having, I would say, eye issues, right? Teach patients to report blurred vision or headache. Remind them to have an eye examination before taking the drug, and then every 6 months afterward to detect changes in the cornea, lens, or retina. That's good to know. NCLEX alert. Biological response modifiers are your they are called sometimes your biologics, are one of the newest and most effective classes of DMARDs and include interleukins, tumor necrosis factor inhibitors, okay, and monoclonal antibodies. Any one of the BRM, which is your biological response modifiers, may be tried. So if one drug is not effective, then the doctor is going to try another one of the same class. All these drugs are expensive and insurance companies may not completely pay for their use. In fact, these drugs are administered IV in some functional medicine clinics, and the cost is elevated. That's true. So many patients they prefer to take these IV drugs, these biological response modifiers. and in functional medicine. High risk for developing impaired immunity and subsequent infection are one of the side effects of these biological response modifiers. Instruct them to stay away from people with infections and to avoid large crowds. Again, if possible, remind patients with multiple sclerosis, tuberculosis, or a positive TB test that they should not receive the biological response modifiers because they make patients susceptible to flare-ups of this disease. So any patient receiving the BRM are going to develop flare-ups of multiple sclerosis. We know this is a disease of the myelin sheath, right? Tuberculosis, or they are going to they need to get the patient to have a negative purified protein PPD test or TB, okay, in order to receive this biological response modifier. If not, a PPD skin test is typically administered and the selected BRM is not started until a negative test is confirmed. Yes, we know that. So that's good to know. Okay, other drugs, the newest classification of DMARDs is the Janus kinase, GAK inhibiting drugs, often called the GAK inhibitors. And we have a table here. Okay, so we have the common examples of drug therapy, disease modifying anti-rheumatic drugs. So you don't have to memorize these, but what you need to know is the side effects. For example, the tumor necrosis factor inhibitor, etanercept. Please, first of all, do not confuse this with the antibiotic ertapenem that is given in the hospital. It's a carbamazepine drug, okay? So don't confuse that. And for this special medication, we need to report injection site reaction. We need to see if there is a local allergic response that can cause pain. Okay, now we have in the interleukin section, there is a very well-known tocilizumab. Okay, but we need to monitor the WBC count of patients receiving any of these drugs and also the liver dysfunction. Also, in the JAK inhibitor section, we have the tofacitinib. Be aware that this medication has a black box warning. That's why I highlighted this paragraph in green about the increased risk for cardiac events, cancer, and blood clots when taking this drug. Okay, so nurses, if you are going to work with a rheumatologist, right, or maybe in a clinic that handles functional medicine, or maybe you're going to work in a clinic with autoimmune conditions and you're going to be giving these medications IV, you need to know this. Very, very good. Okay, it is not usual for patients to be taking several disease-modifying drugs such as methotrexate, a BRM, and also an adjunct medication. Each drug works differently to relieve symptoms and slow the progression of the disease. So you have here methotrexate, that is an immunosuppressant, the biological response medication, and another medication. So you have to be aware of all the side effects before giving these medications to the patients. Glucocorticoids, steroids, usually prednisone, may be given for their fast-acting anti-inflammatory and immunosuppressive effects. Prednisone may be given in high dose for short duration, that's called the pulse therapy, or as low as a chronic dose, right? And whenever the longer the longer the period that you prescribe, that the prednisone is prescribed, the high risk for osteoporosis. You have to remember that. Moderate dose short-term tapering bridge therapy may be used when inflammation is symptomatic and other RA medications are insufficient or have not yet had the effect. Chronic steroid therapy, there you go, can result in numerous complications such as diabetes mellitus. They can increase the glucose, the blood glucose, impair or decrease immunity, fluid and electrolyte imbalances, hypertension, osteoporosis, glaucoma. Okay, glaucoma. So the patient is having the risk with rheumatoid arthritis to have eye involvement like retinitis, and on top of that, by receiving the prednisone, they can develop glaucoma. Okay. Cortisone injections in single joints may be used to temporarily relieve local pain and inflammation, have the patient ice and rest the joint for 24 hours after the procedure. Oral analgesics are also sometimes needed during that time. Non-pharmacologic interventions, adequate rest, proper positioning, and ice and heat applications are important in pain management, right? So it's kind of the RISE protocol with the heat applications, extra care. If acute inflammation is present, ice packs may be applied to hot joints for pain relief until the inflammation lessens. The ice pack should not be too heavy. At home, the patient can use a small bag of frozen peas or corn as an ice pack. Heated paraffin wax dips may help increase comfort of arthritic hands. Finger and hand exercises are often done more easily after paraffin treatment to relieve morning stiffness or the pain of late-stage disease. Recommend a hot shower rather than a sponge bath or a tub bath. Safety grab bars, non-skid thread in the tap or shower floor are important safety measures. Hot packs applied directly to involved joints may be beneficial if they are not too heavy, but here we have to monitor the skin, right? We don't want to cause any burns, especially in elder patients. Plasmapheresis, sometimes called plasma exchange, is an in-hospital procedure prescribed by a primary healthcare provider in which the patient's plasma is treated to remove the antibodies causing the disease, the ones that cause the Guillain-Barré. It's the same procedure, plasmapheresis, right, for Guillain-Barré. Although not commonly done, the procedure may be combined with the steroid pulse therapy. We know that the steroid pulse therapy is very short therapy for patients with severe life-threatening disease. Complementary and integrative health, this is me. Hypnosis, acupuncture, imagery, music therapy, or other techniques. Remember, adequate nutrition is an important part of the management of RA. I'm going to explain some other therapies in class, but nutrition is a good start. Obesity should be avoided or treated if present. The inflammatory state may place a greater burden on the metabolism of some essential nutrients. I told you before, obesity puts the body in a chronic state of inflammation. This catabolic state may be related to increased cytokines production, specifically tumor necrosis factor. Teach patient to take any herbal or nutrition supplement under the supervision of a qualified healthcare provider to prevent adverse events and drug, food, or drug interactions. That's the key, right? We need to look for a good doctor and tell the doctors the truth and all the truth about all the supplements we're taking. We don't want to cause any bleeding, any any medication or supplement that could be diminishing the effect of the main medication that the patient is taking, right? So it's very important. Okay, where are we? Promoting mobility, planning expected outcomes. Patients with RA often have decreased mobility related to multiple joint deformities and muscle atrophy. Fatigue and generalized weakness also contribute to decreased mobility, of course. The expected outcome is that the patient will be able to independently perform LDL, ADL with or without ambulatory and assistive devices. So those with RA do not want to be dependent. We need to understand that, right? For example, hand deformities often prevent a patient from opening packages or food, such as a box of crackers. However, the patient may prefer to use the teeth to open the crackers rather than depend on someone else. And that is when we nurses need to be compassionate, and we don't have to be judgmental. Okay, we need to support the patient in their decisions. Care of patients with rheumatoid arthritis. Patients often use large joints or body surfaces that can substitute for smaller ones. Devices such as long-handled brushes can help patients brush their hair. Dressing sticks can assist with putting on pants. Consult with occupational therapy to help patients learn to function as independently as possible. That is very important, to take notes of all the needs of the patient and then transfer that information to the professionals that can help patients with those activities. For example, persistent pain, sleep disturbances, and weakness are associated with increased fatigue. Anemia may also be a contributing factor and may be treated with iron if an iron deficiency anemia is present, folic acid, or vitamin supplements prescribed by the PCP, right? Assess for drug-related blood loss, such as that caused by NSAIDs, by checking the stool for gross or occult blood. Older white women are the most likely to experience GI bleeding as a result of taking these medications, right? We reviewed that before. If fatigue and decreased mobility result from muscle atrophy, the PCP prescribes an aggressive physical therapy program to strengthen muscles and prevent further atrophy. And trust me, those aggressive physical therapy programs work. I am telling you. In addition to identifying and managing specific reasons for fatigue, determine the patient's usually daily activities and teach principles of energy conservation. So we need to enhance self-esteem. The expected outcome is that the patient will verbalize a positive perception of self as a result of interprofessional intervention and a good family support. Good family support, right? Patient and family education. Okay, where is this? I am getting lost. Okay, we were talking about the good support of the patient. Here we go. So, patient and family educational energy conservation. We need to balance activity with rest. These are the most important factors, I believe. Set priorities and delegate, right? When you cannot perform certain activities. Intervention, body image and self-esteem may be affected by the disease process. The most important intervention is to communicate acceptance to the patient. And we have to remember that these patients in the healthcare system are called arthritis personality, because sometimes they are manipulative and demanding. But we need to be compassionate, don't be judgmental, and try to identify the disease in order to understand and to planify nursing care. If needed, consult with mental health professional or religious spiritual leaders to help patients cope with a potentially debilitating chronic disease. So then we have the care coordination and transition management. Patients with RA are usually managed at home, but in some cases they may be institutionalized in a long-term facility if they become restricted to bed or a wheelchair. which is it's very sad, right? Some patients may be transferred to a rehab facility for several weeks to help develop strategies, techniques, and skills for independent living at home, especially if they are living by themselves. Keep in mind that patients with arthritis can become physically disabled. Home care management, basically we need to focus and accommodate and prepare the house for a wheelchair, a walker. We need to put ramps if necessary, and if the patient's financial situation support those changes, right? And also don't forget the handrails and elevated chairs and toilet seats. Self-management education, provide information to the patient and family about drug therapy, joint protection, energy conservation, rest and exercise, and the most important, support self-esteem. Although the patient behavior may be perceived as demanding or manipulative, as I mentioned, self-esteem cannot be improved without this important aspect of interpersonal relationship, meaning that the healthcare team, all the physical therapists, the family, the patient itself, they need to find a good empathy, they need to find good communications and good techniques to improve and to support patient self-esteem. RA may also affect work and social roles. That's another factor. Now, healthcare resources refer this patient to home care nurse, physical therapies, occupational therapies, the Arthritis Foundation. Patients who have severe advanced RA often develop depression, anxiety, excessive stress. So I would say the mental component is as difficult as the physical, as the disease component, specifically in this disease. Okay, so it's not just the swelling of the joints, the drugs, the interaction of the pharmacology or the side effects. No, it's the mental as well. It's, I would say, 50-50. Okay, so we need to work on that. Poor quality of life as a result of pain and deformity. So basically what we need to achieve is pain control, moves and functions in on environment independently with or without assisted devices, and verbalizes increased self-esteem and positive perception of selves. So we finish rheumatoid arthritis. Let's move to gout, and with this topic we will complete this chapter. As I told you before, this is an extensive long chapter that is covering many concepts and disease that we can see in healthcare. Let's move to the video. Let's watch this video related to gout.
Hi, this is Tom from ZeroToFinals.com. In this video, I'm going to be going through gout, and you can find written notes on this topic at ZeroToFinals.com/gout or in the rheumatology section of the Zero to Finals medicine book. So let's jump straight in.
For some reason, this is not the video that I have selected for you guys. So let me see if I can find this video, and I already saw this. Okay, this is the video. Sorry.
Gout is an arthritic disease of your joints caused by too much uric acid in your body. Normally, your liver processes various substances in your body. including purines, which are components of genetic material found both inside your cells and in some foods you eat. When your liver breaks down purines, a waste product called uric acid is produced. Your body disposes of this waste through your kidneys, which remove it from your blood. When your liver produces too much uric acid, or your kidneys do not remove enough of it from your body, excess uric acid accumulates in your blood, resulting in a condition called hyperuricemia. Caffeinated beverages affect the waste removal function of your kidneys by increasing your urine output, which eliminates too much water from your body, a condition called dehydration. Dehydration can result in a higher concentration of uric acid in your body's fluids. When the concentration of uric acid becomes too high from any of these sources, it can no longer stay dissolved. The excess uric acid begins to form needle-like crystals inside your joints, most commonly in your big toe. Formation of uric acid crystals leads to an inflammatory response. White blood cells from your immune system attack the uric acid crystals, resulting in joint pain and inflammation. This is called an acute gout attack. If left untreated, elevated uric acid levels may result in lumpy deposits of uric acid around your joint, called a tophus, causing additional joint pain and disfigurement. Treatment for acute gout attacks includes colchicine to prevent or reduce joint inflammation, non-steroidal anti-inflammatory drugs to reduce pain and inflammation, including aspirin, ibuprofen, such as Advil, Motrin, and Nuprin, naproxen, such as Aleve and Naproxen, and steroid drugs, such as prednisone. Treatment for chronic gout includes drugs that promote uric acid excretion and drugs that inhibit uric acid production by your body. Lifestyle changes to prevent recurrent or chronic gout include reducing red meat and shellfish in your diet, limiting the consumption of alcohol, which is high in purines, limiting caffeinated beverages, exercising regularly, and drinking plenty of water.
Thank you. So when we think about preventing gout, we are thinking about reducing the amount of meat and the shellfish, right? But we are not considering that we need to limit the intake of alcohol and caffeinated beverages. Okay, so we basically know what is the cause of gout, and then we are going to talk about phase 1, asymptomatic hyperuricemia. The patient has an elevated uric acid level, but no arthritic or kidney symptoms. Okay, so there is only elevated uric acid. In phase 2, there is acute gouty arthritis. The patient has an acute attack in one single joint, often the metatarsal joint of the great toe. The patient reports severe or excruciating pain in the inflamed joint. Pain and inflammation may last from several hours to several days and then may resolve without treatment. And then these episodes may occur over months to years. Oh my God. Especially when triggered by alcohol, high protein intake, or certain drugs. Alcohol again. After having multiple gouty attacks, the patient is considered to have chronic gout. And then phase 3, tophaceous arthritis, is the developing of tofu. No, it's tophi, okay? Kidney stones and kidney disease. Due to the effectiveness of currently used drugs, few patients today progress to this phase of gout. So interventions, the goal of treatment for patients diagnosed with gout is to maintain their serum uric acid level to less than 6. First step. Drug therapy is the major treatment modality used to meet this goal. Depends on the phase of the disease. The drugs of choice for an acute gout episode are either NSAIDs, steroid, or colchicine that works by inhibiting the migration of leukocytes to the inflamed joint to decrease inflammation. However, it does not affect uric acid level or prevent additional attacks. So this medication, we need to teach the patient that GI distress may occur, including diarrhea, abdominal pain, nausea, and vomiting. Remember this colchicine because we are going to see this drug when we enter the GI tract. Remind the patients to take the drug with food to help minimize these potential side effects. To decrease a patient uric acid level, the patient may be prescribed uroseric drugs such as probenecid to excrete excess uric acid via the kidney. So for that factor, we need to monitor if the kidney is good, right? Probenecid can be safely administered with colchicine because those are working in different areas. For chronic gout, some patients take a uric acid biosynthesis inhibitor, also known as succin oxidase inhibitors such as allopurinol or befusoxstat. These drugs work to reduce the production of uric acid in the body. And this febusoxstat is the newest drug in the market and has a greater risk for patients to experience an adverse cardiovascular event. Okay, so to help prevent a gouty arthritic attack or flare-up, teach patients the importance of avoiding or limiting substances that can trigger an attack. We all go back to prevention for all single diseases. So red meat, such as ground beef, organ meat, such as liver, shellfish, as a shrimp, alcohol, especially beer. Review the patient's drug profile to identify any medication that could cause a gouty arthritic attack, such as thiazide diuretic. Okay, this medication is going to make the patient go to the bathroom all the time. So whenever there's less fluid in the body, this purine is going to cause high uric levels in the blood. So it's not going to be diluted, it's going to be present, right? If the patient is obese, collaborate with the registered dietitian nutritionist for a referral to a community weight loss program. Ladies and gentlemen, we have completed this chapter. I think it's chapter 43, if I am not wrong. Yes. So thank you for your attention and enjoy the rest of the semester. Thank you.